Hi folks, this is Dr. Patil and I welcome you back to the PrepLadder NEET platform. In this video, we will be studying about the vasculitides or what we call as vasculitic syndromes. Right. Let us begin by understanding the definition. The vasculitides or the vasculitic syndromes can be defined as clinico-pathological disorders characterized by inflammation of and damage to blood vessels. This is the simplest definition I could pick up from Harrison. Because if you go by pathology books or the other resources, you would notice that it is defined variably, because basically we are talking about a set of disorders which share a common feature, that is involvement of blood vessels, but they have different pathophysiological principles or mechanisms and different clinical features and different clinical outcomes. So because of that, bringing all these disorders under one heading of vasculitides or vasculitic syndromes is very, very difficult. Right? Nonetheless, currently what we follow or what we have accepted as a routine classification system is the 2012 Chapel Hill consensus nomenclature classification system. Right? Though I do agree that this is still a work in progress, that is what is in commonplace from 2012 onwards. So we will first understand the classes under the Chapel Hill classification system, and then we will go on to discuss the large vessel vasculitis in this video. In the subsequent videos, we will be discussing the medium as well as small vessel vasculitis. Okay, so let us start with the International Chapel Hill Consensus Conference on Nomenclature of Vasculitis 2012 classification. So according to this classification system, there are 6 major classes of the vasculitic syndromes. Obviously, it is based on the vessel size. So we already are familiar with the 3 syndromes, that is the small vessel vasculitis, the medium vessel vasculitis and large vessel vasculitis. Other than that, the other 3 classes which are not very familiar to some of us, that include variable vessel vasculitis, vasculitis associated with the systemic diseases, and single organ vasculitis. Okay. To start with the large vessel vasculitis, there are 2 important reasons or 2 important causes for us to remember, that include Takayasu arthritis and giant cell arthritis. Right? Those are disorders where mainly large vessels are affected. To some extent, there is involvement of the medium vessels. Now, talking about the medium vessel vasculitis, these are the disorders where medium vessel is predominantly affected. There may be some degree of small vessel involvement. Right? Classical examples are polyarthritis nodosa and Kawasaki's disease. Right? Now, talking about the variable vessel vasculitis, I want you to remember too, when it comes to physician's perspective, obviously we are mainly concerned about Behçet syndrome, and ophthalmologists may be a little more concerned about Cogan syndrome. We will be learning a little bit about both of these as we go along the rheumatology series. Let us now move on to discuss the vasculitis associated with systemic diseases. So basically, these are the disorders where a primary cause or there is some primary disorder which is causing the vasculitis. The typical examples being rheumatoid arthritis or SLE. In both these cases, we can see vasculitis. Okay. Then one example I want you to remember for single organ vasculitis is CNS vasculitis. Right? A classical example for single organ vasculitis. Okay. So far we have discussed 5 classes. Now coming to the small vessel vasculitis. This we have further classification according to the Chapel Hill itself. So these can be divided into ANCA associated vasculitis or vasculitic conditions and immune complex mediated vasculitic conditions. Right. What are the ANCA associated? 3 things particularly are classical examples: microscopic polyangiitis, then vaginous granulomatosis, or what we currently call as granulomatosis with polyangiitis, and the last one is EGPA, eosinophilic granulomatosis with polyangiitis, or what we are very much familiar with as Churg-Strauss syndrome. Right. So these are ANCA associated small vessel vasculitis. Right. Now talking about the immune complex mediated, here we have anti-GBM, cryoglobulinemic vasculitis, Henoch-Schönlein purpura, or what we currently call as IgA vasculitis, and the last one being hypocomplementemic urticarial vasculitis, which is also known as anti-C1q syndrome. Right? So these are immune complex mediated vasculitis. Now, so far whatever we have discussed, right, this is one important area for MCQs. Very often they may ask you, like once you are very much familiar with this topic, this becomes a very simple or easy question. But when you are not familiar, this can be considered as a difficult question. So they may ask you, which one of the following is a small vessel vasculitis, or which one of the following is not a small vessel vasculitis, or not a medium vessel vasculitis according to the Chapel Hill classification criteria. Right? So this is one important point to note. What I have observed is, of late, I have seen 2 or 3 MCQs from the PG level or super specialty level entrances is about the variable vessel vasculitis. So they give option based and then ask you which of the following is a variable vessel vasculitis, right? So variable vessel vasculitis basically means can affect varying sizes of the vessels, right? It can be affecting the small, medium, or large, or anything of that sort, right? Okay, now let us start discussion on Takayasu arthritis. This is one of the large vessel vasculitis, right? So we had two, giant cell arthritis and Takayasu arthritis. Now I'm beginning the session with Takayasu arthritis because this is the most common large vessel vasculitis in India. If you open Harrison or any of the international texts, you would notice that they start with giant cell arthritis because for the Western world, that is the most common large vessel vasculitis. But when it comes to India, and not only India, probably Asia as a whole, this is the most common large vessel vasculitis. The disorder is also known as pulseless disease, right? This is also known as pulseless disease. So in this disorder, there is granulomatous vasculitis of the large vessels. So when we do biopsy, we may notice some degree of granulations. Coming to its epidemiology, right, I have already told you this is the most common large vessel vasculitis in India, and we already know that Asians are more affected than the Western world. So when it comes to Western world or Caucasians, it is the giant cell arthritis which is the most common large vessel vasculitis there, right? Okay, now if you look at the gender distribution, obviously you would notice that females are more affected than males, and that holds good even in case of giant cell arthritis. So there also females are more affected than males. And if you look at the age distribution, right, you would notice that a typical case of Takayasu arthritis is a young female. We have already known that females are more affected. So it's a typical young female under 30 years of age. If you go by the ACR diagnostic criteria or classification criteria, it goes on to say that the age at onset of the symptom should be less than 40 years. Majority of the patients, when you see, they are usually under 30 years. Since we don't know much about the genetics and pathophysiology, it is really hard for me to keep discussing some research findings which may have some consequence. But one particular point which is kind of emerging as an important observation I want you to remember about genetics is the association with HLA-B52, right? HLA-B52. So there is one Turkish study which has found some reasonably strong association with the HLA-B57. Other than that, we don't know much about the genetics of this disorder. Coming to the clinical features, right? The most patients present with they don't usually present with the acute vasculitic condition. So they mainly present with stenosis or aneurysm of the affected vessels. So like a very classical acute vasculitic presentation is rare. Rather, you would diagnose patient as having Takayasu arthritis when they develop stenosis and they present with the stenotic manifestations of the disorder of the affected vessel, or they develop aneurysms and its consequences, right? Okay, so what is the most affected vessel? Obviously, when we say large vessel, we are generally talking about aorta or something as a major branch of aorta. So here aorta is most commonly affected, and the most commonly affected part of aorta is the arch of aorta, right? So arch of aorta is the most commonly affected part in case of Takayasu arthritis. And if there is an MCQ specifically asking you what is the most commonly affected artery and they don't talk about aorta, right, then think of a branch of arch of aorta. So first thing that should come to my mind is subclavian artery, right? So subclavian artery is the most commonly affected artery. And one more thing I want you to remember about Takayasu arthritis, this is particularly important for us to note, is that literature reports 4 to 100% of cases having reported pulmonary artery involvement. And pulmonary artery involvement in a vasculitic syndrome should make us think the possibility of Takayasu arthritis. Because see, if you talk about polyarteritis nodosa, you would notice that pulmonary artery involvement is extremely rare there, right? When we say giant cell arthritis, it is basically a disorder which is affecting carotid and the intracranial vessels rather than the further larger size vessels. So thus, whenever there is pulmonary artery involvement, when there is a question which talks about the pulmonary artery involvement in a vasculitic syndrome, I would urge you to think of Takayasu as one of the important differentials. Okay, so now we know what is the most commonly affected vessel, right? So it is the arch of aorta which is most commonly affected, aorta in general, arch of aorta, and among the branches of arch of aorta, obviously it is the subclavian, right? So how do these patients present? The most common presenting complaint of patients with Takayasu arthritis is basically claudication of the upper limb, right? So claudication is the most common complaint, and this claudication mainly affects the upper limb more than lower limb, because we are talking about subclavian artery, right? So it is mainly about the upper limb claudication. Other than that, because there is subclavian stenosis, we have already told you that in these disorders there is stenosis or aneurysmal dilation. So because of the stenotic vessels, very often we are talking about subclavian, right? So there will be discrepancy between the blood pressure of two limbs. So that is one more finding that unearths the presence of Takayasu in some patients. So this is one more point to note, and in fact this BP discrepancy is part of the ACR classification criteria, right? And because we're talking about stenotic lesions, patients may have bruit. The most commonly heard site for bruit is subclavian artery. Apart from that, the second most commonly heard site for bruit is abdominal aorta, right? So that is about the bruit. Now some patients also develop a retinopathy, which is called as Takayasu retinopathy. Here I am not talking about the hypertensive retinopathy. I do agree that hypertension can occur, especially in patients who have developed renal artery stenosis. Hypertension can occur, and in fact it can be severe and it can also be refractory, and it can cause retinopathy. But there is also an ischemic retinopathy that is known as Takayasu retinopathy. Right? If it is caused by hypertension, obviously we will call it as hypertensive retinopathy. Okay, so these are the clinical manifestations. Now talking about its serology, right? So now we know the clinical manifestations and a little bit of epidemiology. Now comes the question of diagnosis and evaluation. So let us begin with serology first, right? So there is no specific autoantibody or any diagnostic that clinches the diagnosis. So when we say serology, basically I want you to remember some molecules or substances which have an impact or utility in assessing the disease activity, right? There is definitely no role of serology in case of diagnosis. The diagnosis is clinical, or if required, maybe biopsy. The first serological marker I want you to remember is interleukin 6. Interleukin 6 is generally found to be elevated in these patients, and it correlates with the disease activity, right? The second one is RANTIS. RANTIS stands for regulated on activation normal T cell expressed and secreted. I don't know what sense that makes, but this is a substance, and this statement is summarized in this word RANTIS, right? So the RANTIS levels are also elevated when the disease is more active. Okay. Then the last one is metalloproteinases 3 and 9. 3 and 9. So levels correlate with disease activity, right? So levels of all these three correlate with disease activity. So they can be used as a marker when patient is on treatment, right? There is also a metalloproteinase 2, which levels do not correlate with the disease activity, but it can be useful in diagnosis, right? This can be useful in diagnosis, but it's like they are elevated, the levels are elevated, but its levels do not correlate with the disease activity. More severe it is, more higher, no, nothing like that. Okay. Now coming to the classification of this disorder, Takayasu arthritis. Takayasu arthritis can be clinically classified using the clinical stages and symptoms. That is known as Ishikawa classification system. I think it is not particularly important for the NEET super specialty also. I don't consider it as an important system for classification system for even those who are aspiring for the Central Institute's rheumatology, because mostly it is not routinely used clinically, right? So what we use clinically also is the angiographic classification. So we are talking about vasculitic disorder which causes stenosis and aneurysm, and thus the best way to investigate is probably to do angiogram. And based on the angiogram, the disorder is classified into 5 types, right? So what are those types? We would understand from this slide. Numerous number of MCQs are possible from this slide, so I want you to pay attention, right? So there are basically 5 types, and if you notice from the screen itself, you would notice that the first 2 types, right, type 1 and type 2, the involvement of the aorta is restricted to the above diaphragm, or you can say thorax and above. In case of type 3 to type 5, there is some degree of involvement of abdominal aorta. So this is first point I want you to note. Okay, so let us first begin with type 1. So what is happening in type 1? Type 1 is where there is involvement of the arch of aorta or its branches, right? Arch of aorta or its branches. So that means type 1 is the most common type, right? This is the most common type. Okay. So in type 2A, so type 2 has 2A and 2B. In type 2A, we are just adding one more area of involvement, that is the ascending aorta. Obviously, arch of aorta is part of type 1. Here we are adding ascending aorta. So that becomes the type 2A. and add the descending thoracic aorta to this, it becomes type 2b. So in type 2b, basically everything above the diaphragm is involved, right? That is type 2b. Now I have already told you, when we say 3 onwards, there is some degree of abdominal aorta involvement, right? So what is type 3? In type 3, there is descending thoracic aorta involved, right? That is the above diaphragm component, and there is either abdominal aorta involvement. I repeat my words, either abdominal aorta involvement or renal artery, or both. Renal artery, you would say, is sub diaphragmic involvement. So in such situations, when it's only renal and there is the involvement of descending thoracic aorta, it will be still considered as type 3, right? So that is type 3. In type 4, only the infradiaphragmatic components or abdominal components are affected. So abdominal aorta or renal artery, or both, right? So if there is a question asking you, isolated renal artery involvement in Takayasu arthritis should be considered as which type, right? It should be considered as type 4, because renal artery or abdominal aorta or both, that would be falling under type 4, right? Without the involvement of the supradiaphragmatic aorta, right? So no thoracic, no arch, no ascending aorta. Type 5, often books describe it as a combination of 2b and 4, right? So 2b is what? 2b is where everything above the diaphragm is affected, and in case of 4, either abdominal or renal is affected. So in simple words, type 5 is the extensive one, right? Every part of the aorta is kind of affected. Yeah, within the diaphragm, below the diaphragm, only the renal artery affected or only the abdominal aorta affected, it's still considered as type 5, right? So this is type 5. In type 5, arch is involved, ascending is involved, arch is involved, descending thoracic is involved, and when it comes to abdominal component, it can be like abdominal aorta affected or renal artery affected or both affected, right? So that is what is known as type 5. So some important MCQs are possible from this classification system, so I want you to kind of memorize it and remember it, right? One simple hack to remember is 3 onwards, there is some degree of involvement of the infradiaphragmatic component, or in other words, abdominal renal arteries. In 2b, everything above the diaphragm is involved, right? So with that, you can remember the rest of the things. Okay, now let us talk about the diagnosis. So diagnosis, there is a 1990 ACR classification criteria, which is routinely used by physicians for diagnosis or as a guiding principle for diagnosis. So what does this criteria talk about? It criteria says, among the 6 criteria that are mentioned, if there are more than or equal to 3 criteria met out of 6, right, the case can be classified as Takayasu arthritis. What are those 6 criteria? The first criteria is about age. I have already told you about this, right? Majority of the patients generally present before 30. For the diagnostic criteria, it is 40, right? So age at disease onset less than 40 is the first thing. The second criteria is claudication of extremities, right? I have already told you subclavian artery involvement is the most common manifestation, and thus the upper limb claudication is the most common clinical presentation, right? So claudication of extremities is the second criteria. The third one is the decreased brachial artery pulse. So we already know that this disease is called as pulseless disease, right? So if the brachial artery pulse is decreased in intensity or amplitude, yes, it can be considered as a criteria. Then the criteria number 4 is about blood pressure. Blood pressure difference between extremities or arms of more than 10 millimeters of mercury, right? I have already told this point. Now the next point is hearing the bruit over subclavian arteries or aorta, right? Subclavian arteries or aorta. Again, one more point that we have discussed in the clinical features. The last, number 6 criteria is arteriogram abnormality, right? So if you have done the angiogram and if you notice that there is aorta or subclavian artery stenosis or aneurysm, well, that could be a 6th point or 6th criteria. So if 3 out of these 6 are present or positive, then the case is classified as Takayasu arthritis. Okay, so that's about the diagnosis. Now coming to the management. So when we talk about management, right, the first line agent in case of Takayasu arthritis is glucocorticoids. Usually given in the dose of 1 milligrams per kg OD, right? That is the dosing. And remember, American College of Rheumatology strongly recommends glucocorticoids as the first line agent. right? Now, because most of the patients might require a long-term steroid therapy, as a steroid-sparing agent, you may use second-line agents or as an add-on drugs, right? What are the second-line agents I'm talking about? Mostly they are like in the form of azathioprine or methotrexate. Right? These can be used as second-line agents. Okay. When the disease activity is persistently high despite use of steroids, optimal dose of steroids, as well as maybe adding second agents like methotrexate or azathioprine, you can go for a third line agent. See, one point I want you to remember here is TNF alpha drugs, like anti-TNF alpha drugs like infliximab, have shown excellent results in patients with Takayasu arthritis. So that can be used as a third line agent. Okay, when third line agent fail, TNF alpha agents are not able to be achieving the good disease activity reduction. In such situations, you may use tocilizumab, the anti-IL-6 drug, which we are very much familiar during this COVID pandemic, right? Or there are certain various newer monoclonal antibodies that have been recently launched into the market. Those can be tried when the disease activity is not coming under control with the first three line agents, right? But majority of the patients, if you are a general practitioner or if you are a physician or maybe a rheumatologist, you would be able to handle most of the patients with infliximab itself, right? So that is the point to note here. With this, now let us go on to discuss the next important major large vessel vasculitis, that is giant cell arteritis, right? I have already told you this is quite rare in India. This is basically a disorder which is reported from the Scandinavian countries or the Northern Europe countries. So this is a disorder that mainly affects carotid artery and its branches. So when we say Takayasu arthritis, that is a disorder that mainly affects the arch of aorta and its branches. But when we say giant cell arteritis, it is a disorder that mainly affects the carotid artery and its branches. We already know what is the most commonly affected branch of the carotid artery, right? Temporal artery. So we already know that giant cell arteritis is also known as temporal arteritis, right? Okay. Then one more important point to note about this disorder is the strong association with the polymyalgia rheumatica. What is polymyalgia rheumatica? That is a condition where patients present with the pain and tenderness of muscles and structures around the shoulder girdle and hip girdle, right? And this disorder is separated from the fibromyalgia from the presence of increased ESR. So ESR is extremely high in these patients in comparison to patients with fibromyalgia rheumatica, right? Okay, so another point to note about this is that in case of polymyalgia rheumatica, right, 50% of the patients of giant cell arteritis usually have polymyalgia rheumatica, and around 20% of the patients who are diagnosed with polymyalgia rheumatica go on to develop giant cell arteritis later, right? So there is a strong correlation. Okay, so with this, let us begin understanding the epidemiology. So when we say giant cell arteritis, this is basically a disorder of elderly. So when we say Takayasu arthritis, I've already told you that is basically a disorder of young females, right? So here it is a disorder of elderly. Majority of the cases are diagnosed after 60 or 70 years. For the classification criteria, it says at least 50 is the minimum entry age. So age at presentation should be 50 plus. Females are more affected than males, and most of the cases are reported from the Scandinavia or Scandinavian countries or Northern Europe and US. It is relatively rare in case of blacks and Asians, right? It is rare in blacks and Asians, and it is almost rare in case of India. Right? It's quite rare in case of India. I had told you that there is not much of a strong genetic background in case of the Takayasu arthritis. I only asked you to remember HLA-B52 because a Turkish study reported its significance. But other than that, when it comes to the giant cell arteritis, right? So here there is a reasonable correlation between HLA-DR4 and HLA-DRB1, a particular allele DRB104 confer a very high risk of developing giant cell arteritis. But if there is a question asking you what is the most important risk factor for giant cell arteritis, because it is a disorder of elderly, age is the most important risk factor for giant cell arteritis. Okay. Now, when I was talking about the Takayasu arthritis, I did tell you that I'm not going to get deeper into the pathophysiology of the process because it is not well connected, it is not well established. But when it comes to the giant cell arteritis, the pathophysiology or pathogenesis is somewhat reasonably well known, right? So let us understand a little bit, because maybe in the subsequent years, some newer drugs targeting these particular cascade molecules may come into picture. So we should understand basics. Okay, what triggers the inflammatory event is not known, but one of the initial, very initial step is the activation of dendritic cells, right? So dendritic cells in the adventitia are activated to the activated or mature dendritic cells. That is the initial event. What triggers this transition is not known, right? Mature dendritic cells. These mature dendritic cells then generally go on to recruit CD4 positive T cells, right? So the main abnormality here is the recruitment of CD4 positive T cells. So these CD4 positive T cells will then eventually lead on to secretion of interleukin 17 and interferon gamma, right? Interferon gamma, and these things are responsible for the vasculitis, right? Interleukin 17 and interferon gamma. That is the basic pathogenesis of the disorder. Now coming to the clinical features, majority of the patients present with fever, headache, visual symptoms, malaise, polymyalgia rheumatica, and jaw claudication. Presence of jaw claudication is kind of characteristic. So an elderly female presenting with jaw claudication, one should be suspicious of, right? So fever and various other constitutional symptoms also are important pointers. So when someone 50 plus presents with a constellation of these symptoms, right, we should be suspicious of. And visual symptoms are something which are kind of, I can say, relatively specific among the manifestations we spoke about, right? Other than that, I also want you to note that all these manifestations I spoke about are the secondary to involvement of the temporal artery and the carotid artery and its branches. But 1/3 of the patients also have large vessel involvement, right? So in such cases, they have a very high risk of developing thoracic aortic aneurysms, right? I'm not talking about abdomen, I'm not talking about the ascending. Thoracic aortic aneurysm, and the risk Harrison mentions 18 times than the general population, right? So we have to remember this point also, because 33% of the patients can have the involvement of aorta, mainly the thoracic aorta, and they may have aortic aneurysms. Those aneurysms are having the tendency to rupture and cause complications. Talking about the evaluation of the disorders, right? So when we talk about labs, one thing is very well known to us, that is the association of very high ESR and this condition, right? So there are hardly few conditions where we see ESR more than 100. In an elderly patient, when they present with ESR more than 100, one of the important differential diagnoses should be giant cell arteritis. Obviously not in India. In India, I think I would say tuberculosis still continues to be an important cause for the ESR more than 100, and other than that, the multiple myeloma, right? Those two things should come to our mind. But in the Western world, yes, this is one of the important reasons. So ESR often can be more than 100 millimeters first hour, right? Then another observation is that these patients often have increased IgG levels, right? IgG levels can be elevated in these patients. Now coming to diagnosis, one important point I want you to remember is what is the gold standard for the diagnosis of giant cell arteritis. This could be asked as a potential MCQ point, and we guys are already familiar with this, right? So the gold standard for diagnosis of giant cell arteritis is basically the biopsy. And when I say biopsy, obviously we are talking about temporal artery biopsy, right? So that is the gold standard. But in reality, less than half of the patients require a temporal artery biopsy. I'm talking about the Western world itself. Less than half of the patients require, because we have a more simpler alternative to the temporal artery biopsy, that is doing a ultrasound. When I say ultrasound, basically I'm talking about the color Doppler, right? So color Doppler of the temporal artery itself can be diagnostic in the right clinical context. An elderly patient who has presented with fever, maybe polymyalgia rheumatica, and has visual symptoms, so you are strongly suspecting that this patient may be having giant cell arteritis. If you have a strong clinical suspicion and you do a color Doppler of the temporal artery and you notice that there is halo sign present, right? Halo sign present. If this is present, then the diagnosis is almost certain. You don't need to go for the temporal artery biopsy. You can start treating the case as giant cell arteritis. Okay, in the absence of halo sign, maybe you can further work up, but when it is present, it is almost diagnostic. Okay, nonetheless, we still need to know the ACR classification criteria for giant cell arteritis, according to which there are 5 important parameters, and if 3 or more than 3 of these parameters are satisfied, you can classify a case as giant cell arteritis, right? What are those parameters? The first one is about age, obviously expected, right? So age more than 50. That is like kind of important entry point, right? Then the second thing is new onset headache, patient presenting with new onset headache. The third one is about the temporal artery abnormality. Right? Abnormality can be in the form of tenderness to palpation or decreased pulsation of the temporal artery. These abnormalities, mainly the decreased pulsation, should be unrelated to the atherosclerosis of cervical arteries, right? So that is about temporal artery abnormality on clinical examination. The fourth parameter is the elevated ESR. We know that a reasonable number of these patients would have a ESR more than 100 at presentation. For the classification criteria, a minimum of 50 is required, right? So when patient has more than 50 millimeters on first hour of ESR, you would be giving them 1 point, right? The last one is about abnormal temporal artery biopsy. So if 3 out of these 5 are satisfied, you would be classifying the case as the giant cell arteritis or temporal arteritis. But because of the advent of this color Doppler and its utility, and studies after studies showing that this approach can be followed, currently we don't rely much on the ACR classification criteria in the day-to-day clinical practice, right? So day-to-day clinical practice is centered around the halo sign on the color Doppler, right? So if you have a high clinical suspicion of giant cell arteritis, the first thing to do is, or if there is a clinical question which talks about clinical features of giant cell arteritis and they are asking you what is the next best step, never pick up biopsy, never pick up biopsy, never pick up steroid trial, right? Because we are talking about elderly population, and empirical trial of steroids at such high doses not warranted because osteoporosis risk and complications, GI bleed, the risk is high, right? So we are subjecting the patients for the color Doppler of the temporal artery, and if the halo sign is present, then all we have to do is treat them as a case of giant cell arteritis without biopsy. But if the halo sign is absent, we are talking about a situation where there is already a high clinical suspicion of giant cell arteritis, like the clinical picture is strongly correlating with, but halo sign is not seen on the ultrasound. In that case, we need to proceed further, right? So if the degree of clinical suspicion is extremely high, in such cases, then maybe you can jump with the temporal artery biopsy. But if you have a low or moderate degree of suspicion, in such cases, you can do one more test, that is temporal artery MRI. So why are we talking about temporal artery MRI? See, I want you to remember one important point. We already know about the halo sign. The second thing we should know is that temporal artery involvement is usually patchy or segmental. It is usually patchy or segmental, and this can be easily picked up by MRI. And because MRI can do that, we can kind of rely on this. So when we subject the patient for MRI, if MRI comes out abnormal, it says that there is segmental inflammation present, right? In that case, when the MRI is abnormal, then go ahead with the temporal artery biopsy. And if the biopsy is suggestive of giant cell arteritis, treat it like giant cell arteritis. If biopsy is negative, maybe you can start evaluating for alternative diagnosis. And if you have done the temporal artery MRI and it is straight away normal, so basically like you suspected, but on ultrasound you didn't find an evidence of halo, right? And you had a low or moderate suspicion, so you did a temporal artery MRI. So our suspicion was relatively weak, and temporal artery MRI turns out to be normal. In that case, you can say giant cell arteritis is kind of ruled out, and I am only going to look for alternative diagnosis, right? So this is the algorithm. I do find this algorithm useful in real practice, as well as this algorithm can be useful in tackling MCQ. So I want you to remember these points, right? Okay, so let us now have a look at the halo sign that we are talking about, right? So you can appreciate from the image that it's a Doppler image, and you can appreciate the vessel and its Doppler color changes. And surrounding that, you can clearly appreciate a halo, right? This is what is known as halo sign. So presence of halo sign in the right clinical context is almost diagnostic of giant cell arteritis, right? Okay, now let us discuss the management. You guys are very much familiar that the first line agent or the drug of choice is glucocorticoids. And in fact, glucocorticoids show remarkable efficacy, right? They show remarkable efficacy. Routinely, what we do is we treat them with 1 milligrams per kg per day for at least 4 months, and then we make an attempt to taper, right? So studies have shown that most patients would require steroid therapy for more than 2 years, right? Generally, most patients will go on to require steroid therapy for more than 2 years. And a peculiar problem is when we make an attempt to taper, there may be flare-ups, right? There may be flare-ups. So in such situations, maybe we can think of second or third line agents. What are those? We will be discussing again. But before that, aspirins finds a particular role here because This vasculitis can also affect the intracranial vessels. It can cause ischemic symptoms. So aspirin 75 milligrams. If you're talking about Western literature, yes, they talk about 81 milligrams. 75 milligram may be helpful in mitigating the risk of the intracranial ischemia. Okay, yeah, I also forgot to tell you that if patient presents with critical visual symptoms, right? When they present with critical vision threatening visual symptoms, in such situations, you may use higher dose steroids, like in the form of methylprednisolone, 1 gram IV OD for 3 to 5 days. So you guys are familiar with this steroid regimen because we do use it in various other disorders like say neuromyelitis optica or multiple sclerosis, various other situations, right? Okay, now coming to the next important drugs. I want you to note particularly about TNF alpha because when we were talking about Takayasu arthritis, I did tell you that TNF alpha agent means anti-TNF alpha agents have an excellent response there, right? So they become one of the important step in the medication. If steroids are not helping, if the added immunosuppressant agents are not helping, then we are banking on TNF alpha drugs, right? But in case of giant cell arthritis, the anti-TNF alpha drugs are not particularly helpful. Like for example, there was one trial conducted by Hoffman et al. On infliximab, which did not show any benefit. In fact, it showed a little tendency towards harm, right? So this is one important MCQ point. I do sense that they can ask MCQ, so remember about this. Okay. Now the next drug I want you to know about is tocilizumab. We know this is an anti-interleukin 6, right? I don't think anyone can forget about this because COVID has made this drug memorable, right? So there are studies which show that tocilizumab, when given in the backdrop of patient already receiving steroids, it shows excellent response. And when the comparison studies were done, tocilizumab is more effective. Toci is more effective than glucocorticoids. Right? So it is more effective than steroids. The story is similar for another drug called abatacept, which we know it's a CTLA4 immunoglobulin, right? CTLA4 Ig drug. This drug is also superior. So abatacept is also superior to glucocorticoids when it comes to the management. So these can be used as the reserve drugs when glucocorticoids fail, right? Now, if there is a circumstance where patient only has polymyalgia rheumatica and there is no manifestation of giant cell arthritis, right? In those cases also the drug of choice is corticosteroids, but at a lower dose, right? We are using at a lower dose. So instead of using 1 milligram per kg, that roughly transformed to 50 to 60 milligrams for most patients, here we use around 10 to 20 milligrams per kg, right? And we already know that there is a strong risk between giant cell arthritis, so we might have to monitor those patients for the development of giant cell arthritis. Main thing that helps us to monitor PMR patients and overall in giant cell arthritis, when we say that disease is under control or the activity is still florid, it depends on ESR, right? So ESR is the modality for monitoring the disease activity, clinical plus ESR. But when I was talking about Takayasu arthritis, I did tell you that there are certain molecules like RANTES, interleukin 6 levels, and certain metalloproteinases 3 and 9. Those can be used in case of the Takayasu arthritis. So here mainly we are banking on ESR. Right. Guys, I do sense that there may be important questions coming from this topic, mainly about making the decisions in terms of management, especially when glucocorticoids have failed. So we should be very much aware about and sure about the second, third and fourth line agents. So I have tried to make a summary of both Takayasu as well as giant cell management in the form of first, second, third line and fourth line agents. So if you talk about giant cell arthritis, or for that matter even Takayasu arthritis, we know that glucocorticoids are our first line agents, right? But the second line agent and third line and fourth line start differing there. So when we say Takayasu arthritis, we are mainly using the second line agents as steroid sparing agents, right? Methotrexate, azathioprine, mycophenolate mofetil or leflunomide. But when it comes to giant cell arthritis, probably we are looking for an add-on benefit, not as a steroid sparing agent, but as an add-on benefit. In such situations, generally what routinely followed is methotrexate, but you can also use tocilizumab or abatacept. Okay. If you talk about the third line agent, I've already told you that anti-TNF alpha agents like infliximab have a good response in case of Takayasu arthritis, so they become our third line. Okay, and the tocilizumab, the anti-IL-6 and rituximab are considered as fourth line agents in case of Takayasu. But when it comes to giant cell, I've told you that anti-TNF alpha agents were not shown any benefit in trials, and in fact there was a little tendency towards harm. So because of that, the third line agent anti-TNF alpha is out, so we are directly talking about tocilizumab. So something which was a fourth line agent in case of Takayasu becomes the third line agent. And there is also an important role of abatacept, right? Abatacept can also be used as a second. So if you had started with methotrexate as a second line agent, then maybe you can introduce tocilizumab or abatacept as the third line agent. Okay. If toci fails, we already know toci and abatacept are more effective than glucocorticoids. If they also fail, patient continues to have the disease activity. In such situation, you can use ustekinumab or anakinra. Those are our last resorts. Okay, so I hope we have addressed all the important MCQ points. If there are any particular doubts, you can definitely communicate to me on the PrepLadder NEET SS Facebook premium group. And nonetheless, also remember that we will be doing certain important MCQ discussion videos where we will try to take you through the critical MCQ points that you might have not paid attention to while reading the notes or listening to lectures. Okay. Thank you guys for listening till now. We will connect on another video, maybe on the next video, which is about medium vessel vasculitis.